Microscope-integrated intraoperative OCT in the management of large macular holes. Intraoperative OCT gives access to precise and meaningful information about fine macular structures during vitreoretinal surgery. This video describes a patient with a large macular hole undergoing an autologous retinal graft. We will highlight steps of the surgery that can benefit from the use of IOCT guidance. A 25-gauge pars plana vitrectomy is begun in the usual fashion with the addition of a chandelier light. The appearance of the macular hole is confirmed on IOCT, and we confirm that the ILM has already been completely peeled. The next step of the surgery will be perifoveal dissection. IOCT is used to assess the precise location of the viscodissector in relation to the RPE. This will prevent inadvertent damage to the macula. IOCT allows the surgeon to confirm that the edges of the hole have been dissected over 360 degrees. The Huber viscodissector is used to inject viscoat in order to dissect the edges of the hole. IOCT clearly shows the edges lifting up. By injecting with various angles, the edges of the hole are lifted over 360 degrees, a fact that is easily confirmed by the IOCT. Visco should be preferred over cohesive viscoelastics such as Helon due to its shorter duration under the retina. The IOCT scan size can be used to measure the size of the hole and to decide on the size of the retinal graft that will be harvested. By using the 5-line scan as a measuring tool, laser spots can be placed to accurately demarcate the size of the graft. The scanning reticle is first positioned over the macular hole and then displaced to the harvesting location. Harvesting the graft from a nasal location provides tissue with a higher cone density than the temporal retina. Whether there is retinal neuroplasticity at play or the tissue acts as a plug is a matter of debate. PFO is injected into the eye prior to harvesting the graft. The level of the PFO bubble should reach just beyond the marked location for the retinal graft. Because blood does not mix with PFO, this technique limits the need for laser and cautery, thus reducing the scotoma in that area. The viscodissector is used to inject visco to elevate the side of the retinal graft. The graft is isolated using 25-gauge curved scissors. The graft is then moved using max grip style forceps to avoid tissue adhering to the forceps. The graft should be gently slid over the retina and not lifted inside the PFO bubble to prevent the tissue from rolling on itself. Excess tissue is trimmed and endolasers applied to the harvesting location. In terms of graft positioning, IOCT can be used to verify that the edges of the retinal graft are securely tucked underneath the edges of the macular hole. This step reduces the chance of graft dislocation when performing the air fluid exchange and avoids the need for a direct PFO silicone exchange. We suggest fitting the entire graft inside the hole. This is easily confirmed with the IOCT. Care must be taken during the air fluid exchange so that the infusion line is redirected towards the periphery. The exchange should be performed slowly by maintaining a safe distance from the macular hole. Even under air, the IOCT is able to confirm the position of the retinal graft. Air is replaced by an isoexpensile concentration of SF6 and the eye is closed in the usual fashion. In light of recent surgical advancements in the treatment of large macular holes, we'd like to propose the following surgical algorithm. For medium-large holes with a diameter between 400 and 650 microns, the inverted ILM flap technique is preferred if the edges of the hole are already lifted, while perifoveal hydrodissection is suggested if the edges are flat. For holes with a diameter of 651 to 800 microns, In addition to the previously mentioned techniques, autologous retinal grafts and human amniotic membrane plugs should be considered. For very large holes with diameters exceeding 800 microns, autologous retinal grafts and human amniotic membrane plugs can be contemplated early on.